Good afternoon, and it's good to be here. I mean, after lunch, it's a little bit hard to hold people's attention, so I'm going to try. I found the other speakers very helpful and useful leading up to what I'm going to share. I'm a medical anthropologist by training, and I'm professor and chair of health and poverty at the BRAC James C. Brown School of Public Health. So I want to focus on, I'm an academic, but I teach and I do research, and a lot of the work we do is also practice. How do you inform, how does evidence inform programs? How does your teaching inform students to think beyond biomedical public health? So I found the last lot of speakers very helpful because I'm really taking a larger approach to SRHR, sexual reproductive health and rights. And for me, I think what's important is post-COVID, before COVID, endemic poverty continues. I applaud all the countries, including my own country, for making such strides, but there is chronic marginality that exists. There is widening inequalities. And how do we then understand the complexities and intricacies and diversity around sexual reproductive health and rights, not only in Bangladesh, but hearing the speakers from the region where Indonesia and some of the countries are clearly trying to have a much more holistic approach, looking across sectors, because SRHR or gender cannot be siloed, and the longer it's siloed, the problems will persist. So not only do we have sexual reproductive health advances, we continue to have challenges around a whole bunch of unmet needs that were listed by distinguished speakers earlier, but also there's a piling on of other kinds of challenges. Mental health stressors, loneliness, inadequate support for aging populations, chronic diseases, post-COVID, continued sort of other kinds of impacts on jobs, livelihoods, and even what we don't tend to talk about in a much more sort of, the communities we deal with are very diverse. Class, religion, caste, age, location, identity, poverty, access to resources, social capital, lack of, economic capital, lack of, all impact on sexual reproductive health and rights. We're dealing with uneven healthcare systems, privatization, a whole system of informal providers. We've got a lack of accountability. We're dealing with over-biomedicalization, and we're also dealing with commercial determinants of health. And that's in this region and around the world. So for me, what continues is stigma, social taboos, conservative views, challenges, despite all the wins. There's climate change that adds another dimension to it. Global conflict, rising inflation, unemployment, fuel increases in the economy. I'm not here to bring you the doom or gloom, but as someone who's been working in Bangladesh for over 25 years, I think we also have to balance it with realistic discussions and thinking and strategies. And for me, it's through education, through research that then informs programs and interventions across sectors. We have advantages that we have a lot of history, culture. We've had civil society organizations. We've had instability in our countries, but yet we've had a lot of movements by civil society and others dedicated to improving women's lives, along with organizations, NGOs, INGOs, UN, etc. We also have fantastic partnerships and private sector. But I think we need to kind of start shifting the way we teach public health and understand SRHR in our schools of public health. We tend to cut and copy and paste from the north. Well, while some of it's useful, it doesn't fit into our context. For us, sexual reproductive health, and actually for many countries, is immersed in the social, the economic, the political, the religious. I'll give you an example. A young girl, Fatima, I was doing an ethnography with her for 2 years. She was selling toys on the streets. She was 8 months pregnant. She didn't have the money to get ANC care, let alone PNC care. Tell you another story of a young woman that I met, an older woman, younger woman, swapped the stories. They remained the same. She was looking for water, very little water in the settlement she lived in. She decided not to drink much water while she sold also goods on the streets, towels. What does she get? UTIs. UTIs means medicines, money, running around. I don't think these stories are unusual. These stories are actually quite common for those who remain chronically marginalized across the region. We also don't talk about impoverished young men. If we don't deal with the problem of young men, or we don't include young men in our discussions, we're putting all of it on young women. A young girl gets married to whom? A male. A young girl makes decisions around family planning with whom? With a male, with a mother-in-law, with her husband, with family. We need to stop discounting young men if we're going to work on sexual reproductive health and rights. Finally, I wanted to talk a little bit about the way we teach means moving beyond sexual reproductive health as a biological and a siloed way, but really looking at it in terms of intersectionality, in terms of practice. What does equity mean? What does community justice mean? I think we need to bring these values and ethics back, not only in our teaching and learning, but to unlearn what we know. Research is very powerful. I do research, that's how I survive as an anthropologist. But most importantly, I think it's very important to realize knowledge is power. And there's a hierarchy of research. And usually, the hierarchy in public health research, at least in South Asia, and I would say in some parts of Africa, is being primarily underpinned by epidemiological methods, clinical or facility-based methods, or disease-specific methods, which are all useful. But it's missing something. Social science qualitative research. Communities are diverse, age variation, economic variation, caste, class, all kinds of variations. We need ethnographies, we need anthropologists, we need ethics, we need political scientists, we need multidisciplinary approaches to understand evidence, to examine gender, but to also understand the multiple forces and layers and barriers and facilitators to sexual reproductive health and rights. It's a huge area, a huge diverse group, and you've got young women, you've got older women, you've got widows, you've got women with disabilities. However, most funding agencies seem to prefer biomedical positivist approaches. We really need to, as a South to South, start pushing for curricula that aligns with our context. We need to push for social science research, which means governments, ministries need to invest in research beyond the standard siloed biomedical. Finally, I want to add with what are the mechanisms that we can monitor each other? I don't know, maybe some solidarity, easier visas, respectful sort of for each other sort of learnings and lessons. I think it begins with respect. We've achieved a lot. We also have a lot of challenges. What can we learn from each other? It's not just about best practices. We carry a lot of history, within that a lot of capacities. Can we capacity share in ways that we can learn from each other? And putting basic political agendas aside, I think failures often teach us a lot more. We may be scared of failures, but you know, I feel every time I attend a meeting or a discussion, when someone shares a failure, we really learn a lot. So for me, it's about changing curricula, adapting it to practice, making it broader about human beings and communities, moving away from silos, and research that is inclusive of multidisciplinary perspectives will give us much more information and far more programs and interventions that are tailored to the needs of SRHR. So let's start sharing. Thank you very much.